Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mamines, breast surgical oncologist. I work at Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
62-year-old woman with a history of a very early stage ERPR positive, HER2 negative left invasive lobular carcinoma, now with a recurrence after 10 years of adjuvant tamoxifen, with metastasis to the ipsilateral supraclavicular node. So we kind of wanted to discuss, given that this is a recurrence, and sort of the data surrounding that, and for systemic therapy versus what would be the best approach for this particular patient. So she presented with pain kind of in the left chest wall, as well as fullness in the left breast tissue around the implant that she had attributed that to the implant. She has an excellent performance status, is still working full time. So her original history started in 2008 with a right ductal carcinoma in situ, as well as left multicentric ILC. Her gynecologic history is there. She became postmenopausal at the age of 50. She's G4P2, no history of hormone replacement. She uses a little bit of alcohol, but no alcohol no tobacco or drug use. No family history of breast, ovarian, or prostate cancer. In 2008, just to remind you, she had a bilateral mastectomy with bilateral sentinel lymph node biopsy that showed the left multicentric invasive lobular carcinoma and the right ductal carcinoma in situ. She completed 10 years of adjuvant tamoxifen, so that finished in 2018. In February of 2021, after presenting with this discomfort, she underwent a CT scan of the neck. And we'll show you one picture from that in just a bit. But this demonstrated left supraclavicular, subpectoral, and axillary lymphadenopathy, the largest supraclavicular node measuring up to 3.9 centimeters, and incidentally, a multinodular heterogeneous thyroid tissue. Dedicated ultrasound of the neck showed a dominant 3.3 centimeter nodule in the left thyroid lobe, and left supraclavicular lymphadenopathy with a dominant mass measuring up to 4.1 centimeters. The thyroid was biopsied and found to be benign, and the left supraclavicular supraclavicular lymph node showed metastatic carcinoma, consistent with mammary origin. It was estrogen receptor 93%, progesterone receptor less than 1%, HER2 negative, and a Ki67 of 15%. So again, just to remind everyone of the timeline, 2008, then 10 years of tamoxifen, and then being off of tamoxifen from 2018 till February of 2021 before she presents with a recurrence. And so we'll let Dr. Jockelson highlight for us some of the pertinent imaging.
So what we have is on the left, an MRI, a single slice MRI of the post-mastectomy with implant reconstruction breasts. And the only pertinent negative is that there is not a significant fluid collection around either implant. Certainly when you present with a history like that, new fullness after many years of implants, one of the things you also consider if it could potentially be lymphoma, implant-related lymphoma, but at least on this single image, there's not a lot of fluid. You don't see anything else. And on the single slice of the CT scan, you see circled is a large left supraclavicular node. And you can also see here is the thyroid, which is naturally enhanced with iodine here. And you can see the left thyroid nodule that was biopsy proven to be benign. And then it looks to me like we also have a node here in the left axilla, again, only seeing it on the one image.
Thank you so much, Dr. Jockelson. So, Dr. O'Shaughnessy, I might let you start us off. Initially, what treatment would be recommended for this recurrent breast cancer? You know, understanding that we have the CALOR data, which kind of talks about the benefit of chemotherapy for patients with recurrent breast cancer, but in this patient with this very seemingly indolent recurrence and seemingly very estrogen driven breast cancer, what would be your approach for this very active patient with an excellent performance status?
And her recurrence, did she have a PET? It's just a local regional recurrence.
She had a CT and bone scan, which was all negative, with
Negative.
the exception of
It's
the
local regional. You know, and she's 60 now, 62. I probably would treat her with letrozole and one of the CDK4/6 inhibitors. I probably would not go a chemotherapy route, with her. She, she's really got quite bulky local regional disease. Very likely has substantial micrometastatic disease, and so I would treat her with cytoreduction to get the cytoreduction, and then for hopefully hopefully radiation therapy that would really benefit her. So I would probably go the CDK4/6 inhibitor.
And what duration of time would you give to kind of assess the response, and what would be your strategy?
Oh, I thought you were going to say how long you're going to keep her on it for. That I'm like, but usually you start to see response within 2-3 months. If it's indolent disease, though, it can take really 3 to 4 months to really see a nice response. Generally speaking, as long as things were moving in the right direction, I would just keep it going. 6, 8, 9 months. Of course, I'd be working with the radiation oncologist, certainly the surgeon, if there was any role for any surgical debulking. It wasn't clear to me that there was, but with the radiation, we'd work together on that. But you'd like it to get it down to minimal amount of tumor before going on to radiation.
Okay. Can you comment just because I just share this as my patient, and what was raised in the tumor board by my colleagues was just the data that we have for recurrent breast cancer. Kind of the general assumption is that if there's a recurrence, those patients really all need chemotherapy. But I'm hearing you say there's a subset of patients that may not be the case.
Well, the CALOR trial, as I recall, was overall positive trial, but the real benefit was in the triple negative population. The ER positive curves were not that impressive, as I recall, So I'm not sure I would apply the CALOR, but even if not all ER positives, of course, benefit from chemotherapy, and so it doesn't strike me as the kind of biology that would benefit from chemotherapy. And the thing is that if we, I consider her a metastatic breast cancer patient is how I consider her. And the head-to-head comparison of chemotherapy with a CDK4/6 inhibitor in the PEARL trial, basically showed, pretty close to equivalence in the head-to-head comparison, the first line setting. So I just don't think that she would benefit more from chemotherapy than from a CDK4/6 inhibitor.
Great. And Dr. Mamunis, do you want to comment about?
I had a similar patient recently who actually interesting case who had a lobular carcinoma in situ several years ago, like 10 years ago, underwent bilateral mastectomy, and then almost 10 years later presented with invasive lobular carcinoma recurrence in the chest wall. And the local oncologist had given her some neoadjuvant and axillary metastasis as well. It was a bulky axillary node on the one side. Had some chemotherapy, neoadjuvant chemotherapy, didn't really make any difference. The tumor was still palpable. We saw her, we recommended sort of the CDK inhibitor and endocrine therapy approach, which she had with a very good clinical response. The question there was because there was some potential chest wall involvement, and so that we wanted to downsize as much. But interestingly, then she had actually clinical complete response, underwent surgery, but she still had some muscle involvement. She still had residual disease. And I think to Joyce's point, we still have her on a CDK inhibitor. and we don't know where we should take her off. Every time she comes back, she says, "What should I go off of this?" I'm like, "Talk to your oncologist." But so it's a very lobular carcinoma. It's a very endocrine sensitive. So, but on the other side of things, CDK inhibitors cause very good clinical response, but it doesn't appear to create pathologic responses either.
Right. And we'll see. The Natalie trial is looking at 3 years in the adjuvant setting of a CDK4/6, and of course the Monarch E trials looked at 2 years. So we'll have data. I say to patients, hang with me a little bit. I want to at least treat you per the Monarch E and Natalie. Hang with me, and we'll get more data for you down the road. But we'd like to get this woman some years down the road. That's for sure.
So, Dr. Bermudez, would you, what sort of surgical, let's say we did, 6, 7, 8 months of neoadjuvant or sort of neoadjuvant endocrine therapy with a CDK4/6 inhibitor and an aromatase inhibitor. And let's say that she had very good response, that there was some sort of shrinkage of that supraclavicular node. Is there a surgery that you would recommend at that point?
Would typically don't. I mean, if she actually gets down to almost normalizing the lymph node, I would think that radiotherapy would be the most appropriate recommended approach. If she still has some disease in the node, has bulky node, you could remove it. It's an area that you have to be very careful about, and we typically don't get to the supraclavicular area. But if radiation oncologist says, well, she still has some bulky disease, and then at that time there's no other disease, one can probably remove the supraclavicular node and then radiate. But I would go by clinical response. If she has a very good clinical response and getting essentially to microscopic disease, I think radiotherapy would be as good. But
okay.
Frank and
Dr. Vicini, what are your thoughts about
the
totally
agree with both Joyce and Terry. I mean, obviously you want maximal cytoreduction here, because the typical doses we want to use for microscopic disease. We don't want to have to treat a 4 centimeter node that's not responding or anything like that. So a typical scenario would be give her to 6 to 8 months of treatment, see how she responds, talk it over with the surgeon. If they don't feel surgery is going to be of any benefit, we would then do obviously comprehensive regional nodal radiation therapy. The question would then be how high to go in the supraclav and whether or not to add SBRT or something to that effect. We just have to wait and see. One point though I do want to make, we were talking about PETs. We do use PET scans to help localize our disease a lot. And so if there's ever a situation where you do want to stage the patient or follow the patient, we do fuse those images. For example, if this patient had a PET up front, I would fuse her initial image on the simulation planning CT, because she also has subpectoral nodes. She also has some other areas of concern. So again, a maximal cytoreduction, if there's no role for surgery, radiation therapy, and then depending upon how much it responded to the initial cytoreduction, we would consider additional boost to perhaps the supraclav with SBRT. One other thing too, in her case, you can see right there in the MRI image, the heart is very close to the chest wall. So we're going to have to do something to take into consideration moving that chest wall away from the heart.
Not that much room to move there.
Yeah. Well, with breath hold works about 70% of patients, and it gives us about a 2 to 3 centimeter separation, and it's only about a 10-second breath hold for patients. So it really does help. It really works.
Thank you so much for that. Dr. Vicini, is there a size that would be, Dr. Bermudez said, the radiation obviously more effective if we're talking about microscopic disease. And I mean, is there sort of a size threshold that you'd be looking for to be able to say that you feel like the radiation really adequately treats that?
Well, I mean, ideally we'd want microscopic, but certainly we could consider doing an SBRT boost if we had 1 to 2 centimeter residual in that supraclav. It would be reasonable. But beyond that, we wouldn't be able to do SBRT, for example, the size right there. But if it got it down to about 1, 2 centimeters max, we could do it. So it's variable what people use. Certainly has to be less than 3 centimeters, but the smaller, the better.